Usually when you set out to learn a new language, you start with, the absolute basics, like greetings.
Right, yeah, like asking for directions or ordering a coffee.
Exactly. But what if the language you're trying to learn is written entirely in these jagged, bouncing, squiggly lines?
Oh, man, that is a whole different ball game.
It really is, because these lines, if you learn to read them accurately, they can literally tell you if someone's heart is about to just stop beating.
Yeah, I mean, it is the ultimate high-stakes translation. You're reading the electrical shadow of a human heart, and it's happening in real time.
So, welcome to the deep dive. Our mission today is to decode that exact shadow for you.
We are unpacking the science, the honestly highly unusual history, and the life-saving mechanics of reading an ECG.
Right, the electrocardiogram. We've gone through this dense stack of clinical notes and historical documents to really distill the absolute core of cardiac tracings.
So whether you are, say, a nursing student prepping for clinicals, or just a curious learner, or even someone who just bought a smartwatch with a heart monitor,
Oh yeah, those are everywhere now.
right, understanding these tracings is, well, it's like gaining access to a secret medical code.
Okay, so let's unpack this. Because the history of how we got this technology is, it's just bizarre.
It really is. We are talking about a journey from a rather strange Victorian experiment to a Nobel-winning medical staple.
The story kicks off in 1887, right? In London, with this British physiologist named Augustus D. Waller. And his primary test subject wasn't even a human patient.
No, it was his bulldog.
A bulldog.
Yeah, the famously patient bulldog named Jimmy. So Waller used this primitive, really highly sensitive device called a capillary electrometer.
Which was what,
It
exactly?
was essentially this tiny glass tube filled with mercury and sulfuric acid.
Hmm.
And he noticed that the meniscus, like the surface of the liquid, it would pulse slightly in response to minute electrical changes.
Oh, wow, okay.
So to capture the electrical activity of a beating heart, Jimmy the bulldog had to stand with his paws actually submerged in glass jars of saline solution.
Oh, wait, literally standing in jars of salt water.
Exactly. The salt water acted as the conducting electrodes.
That visual is just a bulldog in jars of salt water in a Victorian lab. It's hard to shake. But Waller actually totally dismissed his own invention, didn't he?
He did, yeah. He reportedly said he didn't think it would ever find a place in everyday medicine. He just viewed it as a physiological curiosity.
So who actually saw the clinical potential? Who turned that into a real diagnostic tool?
That was a Dutch physiologist named Willem Einthoven. So between 1901 and 1903, Einthoven engineered this thing called the string galvanometer.
Which I imagine was, a pretty massive upgrade from a tiny tube of mercury.
Oh, massive, both in sensitivity and, well, just its physical footprint. Waller's device sat on a little table. Einthoven's machine weighed hundreds of kilograms.
Hundreds. Good grief.
Yeah, it used a microscopic, silver-coated quartz wire suspended between the poles of this tremendously powerful electromagnet.
Wow.
And the magnets were so intense that the machine needed constant water cooling. It actually took an entire team of technicians just to operate it in its own dedicated room.
Mm-hmm. And the patient experience wasn't exactly streamlined yet either. Instead of the bulldog's paws, human patients had to sit in a chair and plunge both hands and one foot into these large buckets of saline.
Right, just to get a reading. And those were basically the first three-limb electrodes.
But Einthoven quickly proved he was a visionary, though. Like in 1906, he realized he didn't even need the patient in the same room as this massive hot machine.
Yeah, he successfully sent an ECG reading from a hospital ward straight to his laboratory over roughly 1.5 kilometers of ordinary telephone wire.
Wait, hold on. They were transmitting live medical data over telephone wires a full century before the smartphone.
They really were. He called it the telecardiogram.
How did they even conceptualize the math for that in 1906? The signal degradation alone, the interference, that must have been a complete nightmare to account for.
It was an astonishing feat of physics, honestly. Early signal processing. Einthoven didn't just build the machine and the transmission lines. To make sense of the signals coming over that wire, he created the entire mathematical language we still use today.
Which is how he eventually won the 1924 Nobel Prize, right? For mapping all this out.
Exactly. He mapped the mechanism of the ECG.
And that mathematical language, that's what we see on, every modern medical drama. The famous alphabet of the heart. The P, Q, R, S, and T waves.
Yeah, the classic PQRST.
Which I always just assumed those letters stood for some Latin medical terms, like some ancient anatomical reference,
A lot of people assume that. But Waller, with his original bulldog tracings, he had simply used A, B, and C to label the waves.
Okay, so why did it change?
Well, his mercury tube distorted the signal. It was sluggish, so it didn't capture the really sharp spikes.
Mm.
When Einthoven built his string galvanometer, he mathematically corrected that distortion, and the true waveform emerged.
Right.
So to differentiate his highly accurate waves from Waller's old ABC waves, Einthoven just started halfway down the alphabet at P.
Wait, so it was literally just a random bookkeeping choice.
Pure bookkeeping. He deliberately left the first half of the alphabet available, just in case future scientists discovered earlier, smaller electrical deflections that he might have missed.
That is wild.
Yeah, he just went alphabetically from there.
Yep.
P, Q, R, S, T. And that convention has just stuck around for over 120 years.
Unbelievable. Well, to understand what those letters actually represent biologically, we kind of have to look at the heart differently. We tend to think of it as a mechanical pump, right? A piece of muscle.
Right, but underneath that physical pump, it is fundamentally an electrical grid.
So how does the grid actually work?
To interpret the waves, you have to understand two core concepts: depolarization and repolarization.
Okay, break that down for us.
So when cardiac muscle cells are at rest, they maintain a negative internal electrical charge compared to the outside. They're essentially primed, like a drawn bowstring, just waiting.
And then the signal arrives.
Right. When the signal to pump arrives, these tiny microscopic channels in the cell membrane just snap open. Sodium ions, and a bit later calcium ions, rush into the cell.
And that massive influx flips the internal charge from negative to positive. That sudden electrical flip is depolarization, right?
Exactly. And that electrical flip is the exact trigger that tells the physical muscle fibers to actually contract and squeeze.
Got it.
But once the muscle contracts, the cell can't fire again until it completely resets. It has to actively pump all those ions back out to restore its negative resting charge.
And that resetting phase is repolarization.
Yes. So every single squiggle you see on the ECG paper is just tracking millions of these individual cells undergoing this massive ion exchange at the exact same moment.
So let's trace a single normal heartbeat on the ECG paper for you guys listening. It starts with the natural pacemaker of the heart, right? The SA node.
Yeah, the sinoatrial node sitting high up in the right atrium.
So the SA node fires off its electrical spark. And that wave spreads across the top chambers of the heart, the atria, causing them to depolarize and squeeze blood downward.
And that initial, relatively small electrical spread, that creates the very first little bump on our ECG strip.
The P wave.
Okay, so P wave equals the top of the heart firing. Then the electrical signal hits a checkpoint before it goes down to the main pumping chambers, the ventricles.
Right, it hits the AV node.
And the electrical signal actually pauses there. On the ECG, this pause looks like a flat, quiet line right after the P wave called the PR segment.
It is a crucial pause.
I always like to think of this pause like holding open the elevator doors, you know? The electricity has to pause so the blood can physically load from the atria into the ventricles before the doors shut and the big contraction happens.
That is a perfect way to look at it.
Because if the electricity didn't pause, the top and bottom of the heart would squeeze at the exact same time and no blood would go anywhere. It would just be a mess.
It would be totally inefficient. That vital pause allows for actual mechanical filling. So once those elevator doors shut, the electrical signal just races down the anatomical superhighway of the heart.
Down into the ventricles.
Right, through structures called the bundle of His, the bundle branches, and the Purkinje fibers. It spreads through those massive, thick, muscular walls of the ventricles almost instantaneously.
And because the ventricles are so big and thick, this electrical burst is huge. I mean, this gives us the QRS complex, which is that really tall, sharp, jagged spike that dominates the paper.
Yep, the QRS is pure ventricular depolarization. Now, interestingly, the atria, the top chambers, they're repolarizing, they're resetting at this exact same moment.
Oh, really? At the exact same time as the big spike?
Yes, but the electrical voltage of those massive ventricles firing is so enormous that it completely buries the atrial reset on the graph. The tracing just hides it.
Wow, okay. So finally, after the ventricles squeeze out the blood to the rest of the body, they have to reset for the next beat.
Right, and that ventricular repolarization gives us the final, slightly wider bump on the strip, the T wave.
Okay, so P, QRS, and T. But you know, a lot of beginners look at this perfectly ordered sequence and form a pretty dangerous assumption.
They really do. They begin to think that every single QRS complex must inherently have a P wave triggering it right in front.
But the electrical grid can break down in ways where they completely separate, right?
Absolutely. In certain pathological conditions, like a complete third-degree heart block, that anatomical superhighway between the top and bottom of the heart gets completely severed electrically.
So no signals get through at all.
None. The SA node in the atria just keeps firing out P waves at its own normal pace, but none of those signals ever reach the ventricles.
So what do the ventricles do? Just stop.
Well, eventually they realize they are starving for a signal, and they start firing completely on their own. They rely on backup pacemaker cells at a much slower, kind of desperate pace, creating their own QRS complexes.
So the top and the bottom of the heart basically just completely divorce each other.
Yes, it's called AV dissociation. On the ECG, you'll actually see P waves marching along completely independently of the QRS complexes. They might even overlap or hide inside each other. The mechanical coordination is just entirely lost.
Which brings up a huge point. Because if the ECG flawlessly tracks this electrical elevator, and we see all the waves in perfect sequential order, P, Q, R, S, T, then a normal-looking rhythm must mean the heart is pumping blood perfectly, right?
See, this raises an important question. If we are only looking at the electrical shadow of the heart, how do we confidently diagnose what's actually happening inside the plumbing?
Right.
Because that assumption you just made, that a perfect electrical rhythm equals perfect mechanical pumping,
Right.
is quite literally the most fatal trap in all of cardiac care.
It seems so intuitive, though. Like, if the electrical trigger fires perfectly, the muscle should squeeze perfectly.
Yeah.
Where does that break down?
The ECG measures electricity, and only electricity, period. It does not measure physical movement. It does not measure blood pressure.
Okay.
There's this terrifying clinical state called pulseless electrical activity, or PEA.
PEA.
Right. In PEA, a patient is in full cardiac arrest. Their heart muscle might be entirely blown out from a massive heart attack, or they might have bled out internally. The muscle is not moving, and they have zero pulse.
But what does the monitor show?
If you look at the ECG monitor, the electrical conduction system is still firing signals into dead or empty tissue. So the screen might show an organized, nearly perfect PQRST rhythm.
That is terrifying. So a nurse or paramedic could look at the monitor, see a great rhythm, and assume the patient is fine while the patient is literally dying right in front of them.
Yes, this is exactly why experienced clinicians constantly drill the phrase, treat the patient, not the monitor. A healthcare provider must physically touch the patient and check for a pulse.
You can't just glance at a screen.
Exactly. You cannot assume blood is flowing just because the electricity is firing. The map is not the territory.
Wow. And that completely shatters that medical TV show trope, right? Where the monitor goes to a flat line, the machine goes beep, and the doctors immediately jump on the patient's chest to do compressions.
Oh, the PV flatline trope is another massive misconception. Yeah. I mean, while a true flatline, a state called asystole, is indeed a fatal cardiac arrest rhythm, a flatline on a monitor is far more frequently just a disconnected sticky pad or a broken wire.
It's just a technical glitch.
Right. Or a dead battery in the patient's telemetry box, which is that little portable monitor pack they wear around their neck on the hospital ward.
So if you just jump on their chest.
If you reflexively start doing aggressive chest compressions just because the screen went flat, you might literally be breaking the ribs of a perfectly healthy patient who just rolled over in bed and pulled a wire loose. So again,
Yeah.
check the patient first.
So if we know the shadow can deceive us, clinicians must have a system to decode the actual truth of the tracing. And it seems like the secret lies in the math of the physical grid paper it's actually printed on.
Yes, the paper grid is highly standardized. It converts physical distance on the page into very precise measurements of time. To read the language, you have to know the speed.
Which is what?
Standard ECG paper moves out of the machine at exactly 25 millimeters per second.
Okay, 25 millimeters a second. And the paper is covered in this tiny grid of boxes. One small box is exactly 1 millimeter wide.
Correct.
So because the paper moves at 25 millimeters a second, that tiny box represents exactly 0.04 seconds of time.
You got it. And those small boxes are then grouped into larger boxes outlined by a thicker line. One large box is 5 millimeters wide, which equals 0.2 seconds.
Okay, so a large box is 0.2 seconds. I feel like a really common beginner mistake would be assuming that one of those big boxes is 1 full second.
It is a very common mistake.
Yeah.
But if one large box is 0.2 seconds, you actually need 5 of those large boxes strung together to make 1 full second.
Oh, right. Basic math. And knowing this grid allows a clinician to just use their eyes and maybe, a pair of little calipers to measure how fast the heart is beating without pulling out a stopwatch. There's that famous shortcut, the 300 rule.
It is a brilliant bit of mental math.
Yeah.
So if the heart rhythm is regular, you just count the number of large boxes between two of those tall R waves, the big spikes. If they are exactly one large box apart, the heart rate is 300 beats per minute. 2 boxes apart is 150. 3 boxes is 100. 4 is 75. 5 is 60.
So a clinician can estimate the heart rate from across the room at a single glance just by looking at the gaps.
Exactly.
But what happens when the rhythm is chaotic and totally irregular? Like in atrial fibrillation, where the atria are just quivering, the gaps between the R waves are going to be completely different sizes on every single beat.
The 300 rule instantly breaks down there. You can't use it.
So what do they do?
Instead, clinicians look at a standard 6-second strip of paper, which is usually marked off by hash marks at the very top of the page. They simply count the total number of QRS spikes in that 6-second window and multiply by 10.
Oh, that makes sense, because 6 times 10 is 60 seconds.
Right. That gives you the 60-second heart rate, even if the beats are wildly irregular.
Okay, so that's rate and rhythm. But a single strip of paper is ultimately just one vantage point. To really see the full three-dimensional electrical field of the heart, clinicians rely on the famous 12-lead ECG.
The gold standard.
But the math here is initially super confusing for people, because it's called a 12-lead, but the nurse only places 10 physical sticky pads, or electrodes, on the patient's body. 4 go on the limbs, 6 go across the chest. So where do the 12 views actually come from?
They're generated through vector mathematics.
Oh, math again.
Right. The machine continuously compares the electrical voltage differences between varying combinations of those 10 physical electrodes. It mathematically generates 12 distinct viewpoints, or leads, of the heart.
And Einthoven started this, right?
He did. He started this concept with Einthoven's triangle. He proved that the 3 standard limb, leads lead 1, lead 2, and lead 3, form a perfect equilateral triangle around the heart.
Wow.
The math is so precise that lead 2 always equals the exact electrical voltage of lead I plus lead 3.
That's amazing. I always picture this using a sports broadcast analogy.
Oh, yeah. Let's hear it.
So a 12-lead ECG is essentially the Super Bowl TV broadcast. The heart is the football field. Lead 2 is the camera directly behind the quarterback, giving you the vertical view from head to toe.
Okay, yep. Lead V1 is the camera down on the sideline, giving you the horizontal cross-section. You need multiple camera angles to definitively prove a receiver's feet stayed in bounds, right? In medicine, you need all those angles to prove a heart attack is actually happening.
That is exactly how it works. Because a heart attack, an infarct, where the tissue is actually dying from lack of oxygen, it's localized physical damage.
Right.
So if the bottom wall of the heart is dying, you will only see the electrical warning signs in the specific cameras physically looking at the bottom of the heart, which are leads 2, 3, and AVF.
So a doctor can't just look at one weird squiggle on a single lead and declare a massive heart attack.
Never. Diagnostic criteria for a STEMI, which is a massive acute heart attack, specifically require ST segment elevation in 2 anatomically contiguous leads.
Contiguous meaning next to each other.
Right. You need 2 adjacent camera angles showing the exact same disaster to confirm the tissue death is real and not just, a momentary artifact from the patient coughing or moving around. That makes total sense. Now, if the ECG is this incredibly sensitive grid capturing every tiny electrical shift, I imagine a localized heart attack isn't the only thing that disrupts the signal. What happens if the blood itself is chemically off?
This is what gets fascinating. If we connect this to the bigger picture, the ECG isn't just a cardiac tool, it's a systemic warning system.
Meaning it looks at the whole body.
Exactly. It can act as a real-time bedside blood test. Take hyperkalemia, which is dangerously high potassium in the blood.
And potassium is heavily involved in that repolarization resetting phase we talked about earlier at the cellular level.
It absolutely drives the reset. So when potassium levels get too high in the bloodstream, the concentration gradient outside the cell gets totally ruined. The cells can't reset properly.
So how does that show up on the paper?
The ECG changes in a very predictable, staged sequence. First, the T waves, the repolarization waves, they get extremely tall and pointy. They appear peaked.
Okay, peaked T waves.
Then, as the potassium level worsens, the QRS complex gets really wide and sluggish. The P waves flatten out entirely and just disappear.
Wow.
And finally, the tracing turns into this terrifying, smooth sine wave right before the heart muscle becomes fully paralyzed and stops.
So an emergency room doctor can look at that sine wave and instantly know the patient has a critical chemical imbalance without having to wait like 45 minutes for the laboratory blood results to come back?
Exactly. It's an instant visual lab result. And it also reveals hidden microscopic anatomy.
Like what?
Well, in 1930, a condition called Wolff-Parkinson-White syndrome was described. Some people are just born with a microscopic extra electrical pathway that physically bypasses the AV node.
Oh, so it bypasses the elevator door pause.
Exactly. The electricity takes a shortcut and bleeds into the ventricles too early. The ventricles start depolarizing sluggishly before the main signal even arrives.
And how do they spot that?
On the ECG, this shows up as a shortened PR interval because the pause is missing, and a weird slurred upstroke on the QRS complex called a delta wave.
That is so cool. So clinicians deduced the existence of this tiny anatomical pathway just by looking at the electrical shadow, decades before modern imaging could ever actually visualize the physical tissue.
Isn't that incredible? They just read the shadow.
The sources even mention it can detect environmental factors, too. Like the ECG can literally tell you if someone is freezing to death.
It can. In severe hypothermia, a distinct extra hump actually appears right after the QRS complex. It's called an Osborn wave.
An Osborn wave.
Yeah, it is a stunning visual reminder that the ECG reflects the entire physiological state of the human being, core body temperature included.
But, with all these incredibly specific visual patterns, delta waves for bypass tracks, sine waves for potassium, Osborn humps for hypothermia, why are human eyes still required to read these things?
The automation debate.
Right. I mean, computers can drive cars and write complex software code today. Why is an algorithm so easily fooled by a squiggly line that a tired nurse at 3 a.m. is legally required to double-check its work?
It is a massive debate, and it really revolves around automation bias. Modern ECG machines, they always print a handy computerized interpretation at the very top of the page.
Like normal sinus rhythm or something.
Right, or consider anterior infarct. But studies consistently show that algorithms frequently misread subtle ischemic changes. That's where the heart is starving for oxygen but hasn't fully died yet. Or they misread rare arrhythmias.
But I'd imagine if a clinician is overworked or maybe just lacks confidence in their own interpretation skills, the temptation to just blindly trust the machine's printed label must be overwhelming.
That temptation is highly dangerous. Medical guidelines strictly mandate that a qualified human must overread the machine. You simply cannot surrender clinical judgment to software.
It's just too risky.
Way too risky. And this is especially true because of confounders like LBBB, which stands for left bundle branch block.
Okay, so how does a block on one side trick the computer?
Well, if the left branch of that electrical superhighway is physically blocked, the electrical signal cannot take the fast lane. It has to detour slowly through ordinary, non-specialized muscle tissue just to get to the left side of the heart.
Okay, so it takes a scenic route.
A very sluggish scenic route. And this detour massively distorts the QRS and the ST segment and makes them look wide and bizarre. But more importantly, it completely masks the normal electrical signs of a heart attack.
Oh, wow.
Yeah, the machine gets hopelessly confused by the detour. Human experts actually had to invent an entirely new set of rules in the 1990s called the Scarbosa criteria, just to visually diagnose heart attacks when an LBBB is present.
That's wild. We're just constantly learning how this electrical shadow can trick us. Look at Brugada syndrome, right? Which was only defined in, 1992?
Yes, 1992. And Brugada syndrome completely overturned old assumptions. It is a genetic electrical anomaly.
Meaning?
Patients with Brugada have structurally perfect hearts, no clogged arteries, no dead muscle, but their electrical ion channels are faulty at a microscopic level.
So the hardware is fine, but the software is glitching.
Exactly. It produces a very specific, bizarre ST segment pattern in the chest leads, and it can cause sudden, fatal cardiac arrest. It proved that you don't actually need physical heart damage to have a fatal arrhythmia. A pure software glitch in the ion channels can be just as deadly.
Which I think perfectly dismantles the biggest misconception of all here, the normal ECG trap.
Oh, yes.
Because say a patient comes into the emergency room with chest pain. The tracing looks completely normal. They naturally assume they're 100% fine.
But a completely normal ECG does not rule out a heart attack.
Wait, really? How?
Well, if you are having a heart attack on the posterior wall of your heart, the very back, the standard 12-lead placement, doesn't actually have a camera angle pointing directly at it.
Oh, so the front looks totally fine while the back is literally dying?
Exactly. Furthermore, if the heart attack is in its very first hour, the electrical changes might not have even manifested on the skin surface yet. It takes time.
Ah, okay. This explains why ER protocols don't just do one ECG, declare it normal, and send you home.
Right. They do serial ECGs.
Meaning they repeat them every 15 or 30 minutes to catch any delayed changes. And they draw your blood to look for biomarkers like troponin, which is a protein that physically leaks out of dying heart muscle cells.
You have to combine the electrical shadow with the chemical reality. One tool is just never enough.
So bringing this all together, we are talking about a 120-year-old technology, right? Yet its footprint in modern healthcare is absolute.
Oh, it's everywhere.
It's universally used because it's cheap, it's completely painless, and it gives you answers in under 60 seconds. I mean, it dictates how we manage hospital wards, with nurses continuously monitoring telemetry and having to expertly manage alarm fatigue from all those false alerts.
It also directly guides life-saving interventions. Like when someone is in cardiac arrest, the ECG immediately identifies if the rhythm is shockable.
Like ventricular fibrillation, where the heart is just quivering chaotically.
Right. It tells the medical team exactly when to use a defibrillator to reboot the whole system.
And now we have this modern twist. Eindhoven's massive room-sized machine is literally strapped to our wrists right now.
It really is. Millions of consumer smartwatches can now record a single lead ECG to detect arrhythmias like atrial fibrillation.
We have basically brought the hospital into the living room. But that also means we've brought all the hospital pitfalls, the false positives, the limitations of only having one single camera angle, and the massive automation bias of just trusting a digital alert straight to the average consumer.
And if the ECG has taught us anything over the last century, is that we can look right at a perfect electrical rhythm on a screen while a patient's heart is mechanically standing completely still.
Right.
So we really have to ask ourselves, what other digital metrics in our modern lives are we blindly trusting? Simply because we've confused the measurement for the reality itself.
The map is not the territory. The squiggly lines are just the shadow. They're not the beating heart itself. Well, thank you for joining us on this deep dive. Keep questioning the world around you, keep looking past the surface, and we will catch you next time.